Emergency airway management. Hello everyone and welcome back to my YouTube channel Dopamine and Decisions. Today's topic is emergency airway management. This is arguably one of the most important skill in emergency medicine. Unlike many procedures, airway management doesn't allow much time for hesitation. Decisions must be made very quickly, but also they must be made correctly. A poorly managed airway can lead to the hypoxic brain injury and cardiac arrest or death within just a few minutes. The good news is that most airway catastrophes are preventable. They happen not because the airway is difficult, but because it wasn't anticipated, preparation was inadequate, or backup plans were missing. So, in this video lecture, we'll go step by step from recognizing airway compromise to basic airway maneuvers and rapid sequence intubation, difficult airway algorithms, rescue devices, and finally the failed airway. By the end of this lecture, you'll have a structured framework that you can apply every time when you are asked to manage an emergency airway. So these are the learning objectives of today's lecture. You should be able to recognize airway compromise, perform both basic and the advanced maneuvers, predict difficult airways, and use adjunct airways as well, understand rapid sequence intubation, and safely manage failed airway algorithms. Part one of our discussion is the airway at risk. Why the airway comes first? Let's start with a simple question. Why do we always begin with the airway? The answer is physiology. The brain has almost no oxygen reserve. Once oxygen delivery stops, irreversible brain injury can begin within 4 to 6 minutes. That's why airway is always the first step priority in the ABCD approach. You can actually replace the blood, you can support the blood pressure, you can even temporarily support the circulation as well. But if oxygen never reaches the alveoli, nothing else matters. This is why emergency physicians often say that treat the airway before it is lost, not after. So let's discuss how to recognize airway compromise. Many people focus only on the oxygen saturation, but remember, oxygen saturation is often a late finding. The patient can have a completely normal oxygen saturation while there is a progressively airway narrowing. Instead, start by listening. Is there a stridor? If there is a stridor, it is indicating that there is upper airway obstruction. If there is a gurgling, gurgling is because of blood secretions or the vomitus within the airway. Is the patient snoring? Snoring isn't normal in an unconscious patient. It is usually means that the tongue has fallen backward and it is obstructing the airway. Now look at the patient. Are the patient using any accessory muscles? Do you see any substernal recession, intercostal retractions, or else if there are any paradoxical chest or the abdominal movements? These are the signs that the patient is struggling to maintain the ventilation. Another very useful bedside assessment is the speech. If a patient can speak clearly in a complete sentences, it means their airway is patent at that moment. Notice I said at that moment. That doesn't guarantee that the patient airway remains patent the whole time. So suppose patients with burns, angioedema, or else there is expanding neck hematomas can deteriorate rapidly. Therefore, always airway reassessment must be done. Emergency airway management is dynamic. Always reassess. Functional anatomy. Now let's review the anatomy that every airway clinician must know. Understanding airway anatomy transforms intubation from guesswork into a controlled procedure. The first important landmark is the epiglottis that you are being shown over here. During direct laryngoscopy, you identify the epiglottis before anything else. If you are using a Macintosh blade, you place it at the tip into the vallecula. Lifting here indirectly elevates the epiglottis and exposes the vocal cords. With a Miller's blade, you lift the epiglottis directly. Ultimately, regardless of the blade that you used, your target always remains the same, that is the vocal cords. These appear as pale white structures forming a V-shaped opening. Never advance the tube unless you are identifying the vocal cords. One of the most common causes of failed intubation is passing the tube without a clear visualization of the glottis. Externally, there is another landmark that is equally important, that is the cricothyroid membrane. Hopefully, you'll never need to perform in surgical airway, but if you do, there won't be time to search for the anatomy. So that is the reason why practice identifying this landmark in every patient. The cricothyroid membrane lies between the thyroid cartilage and the cricoid cartilage. It is the access point during a cricothyroidotomy in a can't intubate, can't oxygenate scenario. Remember that the cricut cartilage is unique because it forms the only complete cartilaginous ring of the airway. Knowing this landmark improves your speed, confidence, and the patient safety during the airway procedures. Next is the predicting the difficult airway. Now we come to one of the most important concepts in emergency airway management, that is predicting the difficult airway before actually giving the paralysis. Every airway should be assessed using the lemon mnemonic. L stands for look externally. Does the patient have any facial trauma, a beard or mustache? Are there large incisors? Is there any large tongue and the obesity? These simple observations immediately provide valuable clues. Next is E. E is for evaluate 3, 3 and 2 rule. Can the patient open their mouth at least 3 fingers breadth? Is the distance between the chin and the hyoid at least 3 fingers? This is hyoid mental distance. Is the distance between the hyoid bone and the thyroid notch at least 2 fingers? This is the thyrohyoid distance. Reduced distances suggest limited space for the laryngoscopy. Next is the M. M stands for the Malapati classification. This has total 4 classes. The mnemonic for this is the push. P is for the pillars. U is for the uvula. S is for the soft palate. And H is for the hard palate. In class 1, you are going to see all 4 of them. Whereas in class 2, you are not going to see the pillars. You are going to see uvula, soft palate, and the hard palate. In class 3, you see only the soft palate and the hard palate. In class 4, you are going to see only the hard palate like it is being shown over here. Class 1 and class 2 are basic one, and these are it is easier to intubate in these patients. Whereas class 3 and class 4 must point you out that the patient is having a difficult airway. Remember that Malampati is only one component of the assessment. Never rely on it alone. Next is O. O stands for the obstruction or the obesity. Patients with epiglottitis, neck swellings, tumor, hematomas, or any severe obesity deserves an extra caution. Finally, N stands for the neck mobility. Limited neck extension due to the trauma, that is because of the cervical collar, or patients with ankylosing spondylitis, or patients who are having previous cervical spine surgeries can significantly increase the intubation difficulty. Remember that a positive lemon doesn't mean that you should not intubate this patient. It means that you should prepare for a better backup plan. Call your most experienced operator. Bring the video laryngoscopy. Keep a bouquet or bougie ready. Prepare a supraglottic airway. Open the surgical airway kit before actually giving the induction agent. Preparation is what prevents the airway disasters. Remember this quote: the difficult airway is rarely the one you didn't intubate, it's the one you failed to anticipate as well. So, in this first section, we have learned why the airway always takes priority, how to recognize early signs of the airway compromise, reviewed the essential anatomy, and discussed how to predict a difficult airway before attempting the intubation. In the next section, we will move from recognition to the action. We will discuss airway positioning, airway adjuncts, bag wall mask, ventilation, and pre-oxygenation. Part 2 of our discussion is basic airway management. In the first part, we learn how to recognize a patient with an airway at risk and how to predict a difficult airway before we commit to the intubation. Now it's time to discuss something that often gets overlooked, that is basic airway management. Many emergency clinicians become so focused on the intubation that they forgot one simple act. Not every patient with airway compromise needs an ET tube. In fact, many critically ill patients can be stabilized with proper positioning, airway adjuncts, effective back valve mask ventilation, and a good pre-oxygenation. These skills saves lives every single day. Next is the positioning and the manual maneuvers. Whenever you approach a patient with airway compromise, the very first intervention should be simple positioning. In an unconscious patient, the tongue loses the muscle tone and falls backward against the posterior pharyngeal wall. This is the commonest cause of the upper airway obstruction in patients with reduced consciousness. And the easiest way to relieve this obstruction is the head tilt and chin lift. One hand gently tilts the forehead backward while the fingers of the other hand lift the chin upward. This moves the tongue away from the posterior pharyngeal wall and restores the airway. However, there is one important exception, that is patients with the suspected cervical spine injury. In trauma, avoid extending the neck because every small movement could worsen the spinal cord injury. Instead, perform a jaw thrust. Place your fingers behind the mandible, behind the angle of the mandible, and lift the jaw anteriorly without moving the cervical spine. It requires slightly more force than a head tilt, but it maintains the cervical spine precautions. One more important point about external laryngeal manipulation is that you may hear some term that like burp maneuver. What is burp? Burp is backward, upward, rightward pressure. Unlike pressure, which has become controversial, burp can improve visualization of the vocal cords during the laryngoscopy. If it improves your view, continue it. But if it is making your view worse, release it immediately. Now let's talk about the recovery position or as a lateral position. Suppose an intoxicated patient is unconscious but breathing adequately and has intact protective reflexes. This patient doesn't necessarily need an intubation. Placing them in the lateral recovery position allows secretions of the vomiters to drain out of the mouth, significantly reducing the aspiration risk. Remember, position first and the equipment second. Okay, this is the exact picture that was given in the 2022 NEET examination as well. This is the recovery position. Left hand to be placed outwards and right hand to be placed behind the patient's head. And the anterior leg has to be flexed at 90 degrees position and the patient has to be tilted towards the lateral side. And face has to be directed towards the downward. So whatever the secretions comes, it gets pulled up and gets secreted outside instead of going into the lungs. This is the way that you protect the patient's airway. Next is the airway adjuncts. Now that we have opened the airway manually, what if it is still not enough? This is where the airway adjuncts becomes an invaluable. Let's begin with oropharyngeal airway or OPA. Another name for this is the Goodell's airway. The OPA prevents the tongue from the falling backward and obstructing the airway. Look at the curvature. It is like the curvature of the tongue. Sizing is extremely important. You measure it from the corner of the mouth to the angle of the mandible or else to the earlobe. Sizing must be appropriate because a device that is too small won't relieve the obstruction. Too large, it can push the tongues backwards and even cause the trauma as well. Avoid inserting an OPA into a patient who still has an intact gag reflex because it can trigger vomiters or the laryngospasm. If the laryngospasm has developed, it would be very difficult for the patient to be intubated. Therefore, OPS are reserved for the unconscious patient without any gag reflex or else without any protective airway reflexes. Now let's discuss about the nasopharyngeal airway or NPA. This is often better tolerated even in the semi-conscious patient as well because it stimulates the gag reflex much less. Measure it from the nostril to the tragus of the ear. Lubricate it well and lubricate the airway as well before advancing it to the airway gently. Never force it. If you encounter any resistance, try it in the opposite nostril. There is one major contraindication to this is the a base of the skull or the severe mid-face fractures. In these patients, an NPA could potentially enter the cranial vault. Although it is rare, this is a devastating complication. So always assess facial injuries before inserting the one. If your bag mask ventilation isn't working well, insert an OPA or NPA. Often improves the ventilation dramatically within seconds. Never underestimate these simple devices. This brings us to the next part of discussion, that is the bag wall mask ventilation. Oxygenation is always more important than intubation. Keep this thing in mind. I'm going to reinforce on this statement again and again during our video lecture. A patient dies from the hypoxia, not from the absence of an ET tube. The biggest challenge with bag wall mask ventilation isn't squeezing the bag. It is obtaining a proper mask seal. The traditional one-handed technique is the easy clamp that works reasonably well, but in real emergency patients with obesity or facial hair or major facial traumas, it is frequently leaks. Whenever another member is available, switch to the two-person technique. That is, one provider uses both hands to create a E&C technique, like it is shown over here, and the other person squeezes the bag. Numerous studies has shown this method delivers significant better ventilation. Now let's discuss about the ventilation targets. Adults should receive approximately 10 to 12 breaths per minute. Each breath should produce gentle visible chest rise, that is about 500 to 600 ml of tidal volume that is being delivered. What is happening here is that the capacity of this bag is around 1500 to 2000 ml. What many people do is that they squeeze the bag completely. It should not be happening like that because our tidal volume would be around 500 ml. So you must squeeze the bag until you see the visible chest rise. That is what we are reinforcing again on the second point. Avoid squeezing the bag too rapidly or with excessive force because it leads to something called as hyperventilation. This increases the intrathoracic pressure that reduces the venous return that worsens the hypotension, and this also inflates the stomach, that is increasing the aspiration risk. Another useful tip is to insert an OPA or NPA like we have seen in the last slide. Remember this phase. seal, lift, ventilate, and reassess. These four words summarize effective bag valve mask ventilation. Next is pre-oxygenation and the apneic oxygenation. Now let's discuss one of the most valuable interventions before intubation, that is the pre-oxygenation. Many clinicians believe pre-oxygenation simply raises the oxygen saturation. Actually, that's not its primary purpose. The goal is to replace the alveolar nitrogen within the lungs with the oxygen. Think of the lungs as an oxygen reservoir. The larger this reservoir, the longer the patient can tolerate the apnea without the desaturation. The standard method is very simple. Allow the patient to take a high concentration of oxygen using a non-rebreathable mask. Alternatively, ask the patient to take 8 vital capacity breaths. Position also matters. Keeping the patient 20 to 30 degrees head up increases the functional residual volume and prolongs the apnea time. In obese patients, use the ramped up position. It means aligning the external auditory meatus with the sternal notch. This also improves both oxygenation and the laryngoscopic views. Now let's discuss apneic oxygen, also known as NOTSAN. Leaving nasal cannula oxygen running at 15 liters per minute throughout the laryngoscopy. Although the patient is not breathing, the oxygen continuously moving into the alveoli because oxygen uptake by the bloodstream creates a pressure gradient. Finally, some patients are already hypoxic before the intubation as well, like patients with pneumonia, pulmonary edema, ARDS, or severe asthma. These often cannot tolerate the apnea. In these situations, give the gentle bag mask ventilation with PEEP or non-invasive ventilation before inducing the patient. This may prevent a catastrophic desaturation. Now let's look at the graph that is being shown over here. The one which is shown in the blue, this is of the normal adult. See, the patient starts desaturating to from below the 90% at the 8th minute. Whereas when it comes to the moderately ill patient, he starts desaturating at half of the time, that is 5 minutes only. If you see the child over here, he starts desaturating around 3.5 minutes only. And if you see the obese patient, he's starting to desaturate at around 2.5 minutes only. Keep this graph in mind because going forward, we are going to talk about the children during the intubation as well, where they have the reduced functional residual capacity, and you need to keep focusing more on the oxygenation. This graph is telling you that. Okay, in normal healthy patients, that's fine, but in children and the obese patients, you need to pre-oxygenate them well. Remember that your goal isn't simply to intubate, your goal is to make smooth transition of the patient from spontaneous breathing to the controlled mechanical ventilation breathing post intubation. With this being said, I would like you to know about another important thing, that is the optimization. The patient has to be optimized for three things, that is for hypotension, acidosis, and the hypoxia. Hypoxia can be dealt with the thing that is called as pre-oxygenation that we are discussing until now, and using the adjuncts and using the supraglottic airway as well, that we are going to see it in the upcoming slides. Acidosis has to be treated with either the soda bicarb infusion if it is the metabolic acidosis, or else by treating the underlying cause. Hypotension can be treated by giving the fluids, and if needed, you need to give the push dose vasopressor or else the inotropics as well. Next part of our discussion is extraglottic airway devices. Sometimes, despite good positioning and excellent bag mask ventilation, intubation simply doesn't happen. This is where supraglottic airway devices become lifesavers. Device like laryngeal mask airway or the iGel that I'm going to show it to you on the next slide can rapidly restore the oxygenation without even requiring the visualization of the vocal cords. They are particularly used after failed intubation attempts, during the cardiac arrest, or as rescue devices while preparing a definitive airway. Insertion is straightforward. Just lubricate the device and insert it along the hard pellet until you feel the resistance. Once you feel the resistance, inflate the cuff if it is required, and confirm ventilation using a waveform capnography. Although these devices ventilate extremely well, remember one limitation is that these are not the definitive airways. They do not protect against the aspiration as effectively as a cuffed ET tube. Therefore, whenever it is possible, they should be viewed as a bridge, not as a final destination. During difficult or failed intubation, sometimes the smartest decision is using a supraglottic airway that restores oxygenation, and you get time to regroup and make a safer plan as well. This is LMA that is being shown over here, and this is the combi tube that is being shown over here. Why this is called as combi tube is that, can you see, you could see there are two ports for two ports. These two ports, one is for the aspiration of the gastric contents and one is for the delivery of the oxygen. Okay, If you see, there are fenestrations over here. Why this is called as a combat tube is that you can place this in either in esophagus or else in the trachea. Okay, if you place it in the esophagus, through these fenestrations, oxygen comes out and it goes inside the trachea. Whereas if you keep it inside the trachea, oxygen gets delivered through this port. This is that is the reason why this is called as combat tube. Extraglottic airway comparison, that is choosing the right tool. Basically, extraglottic airway devices are divided into retroglottic and supraglottic. Combi tube and King's LT tube sit behind or beside the larynx in the esophagus. That is why these are called as retroglottic devices. Whereas LMA and IGL seal above the glottic opening like it is shown in the previous picture. That is why these are called as supraglottic airways. Some devices comes with a port for the gastric decompression as well, like we have seen in the previous slide, and there, it acts as a conduit for the intubation. So this is the laryngeal mask airway that we are seeing over here. So what happens is that if you can confirm the site, you can actually pass a bougie through it. Once you pass the bougie through it, you can remove the laryngeal mask airway, and DT tube can be railroad through it in case of difficult airways. And there are different things that are available for the pediatric sizes. Okay, so this is the combi tube, and this is the King's LT tube. This is the laryngeal mask airway. Supreme, this is the laryngeal mask airway. Next, one more important thing which you need to know is the IGEL. IGEL can be used for the gastric decompression as well because it has another port for the gastric decompression. Basically, whatever the extraglottic airway devices we are talking about, these are to be inserted as a blind manner. Okay, there is no need for the visualization of the vocal cords. One important thing about the IGEL is that can you see the rubber-like structure that is being shown over here? When you insert this inside, what happens is that because of the temperature inside the body, the cuff gets expands and it is sealed at the supraglottic airway. That is the specialty of the IGEL. Let's summarize this section. Successful airway management starts with simple intervention. Positioning the patient correctly, using the head tilt and chin lift or else the jaw thrust maneuvers when it is needed or else when it is appropriate. Insert airway adjuncts when it is indicated. Master bag wall mask ventilation because oxygenation always comes before the intubation. Pre-oxygenate thoroughly, use the apneic oxygen whenever it is possible, and never hesitate to use a supraglottic airway if oxygenation is becoming difficult. These basic techniques forms the foundation of the every successful airway intervention. Part 3 of our discussion is definitive airway management, that is rapid sequence intubation. So far, we have discussed recognizing the airway compromise and mastering the fundamentals of the airway management. What is rapid sequence intubation? Rapid sequence intubation is the near simultaneous administration of induction agent and a rapid onset of the neuromuscular blocker to rapidly produce the unconscious and the paralysis, allowing the placement of the ET tube. Why we perform rapid sequence intubation is that the longer the airway remains unprotected, the greater is the risk of the aspiration, hypoxia, and the failed intubation. The ideal RSA is a single smooth, well-planned attempt. So when we should perform RSA, the first indication is that failure to maintain a patent airway. A patient with severe facial trauma, expanding neck hematomas, or upper airway obstruction may simply be unable to keep the airway open. The second is failure to protect the airway in patients who are with GCS of less than or equal to 8. These patients are unable to protect themselves from the aspiration. The third one is the failure to oxygenation or ventilation despite the maximal non-invasive support. And finally, you anticipate a clinical deterioration in patients. Examples include expanding large neck hematoma, inhalational injury, worsening head injury, or patient need transfer or transport across a cities. Don't wait until the patient arrests. If airway compromise is inevitable, secure the airway while you still have a time to prepare. Now let's look about the classical RSA and the modified RSA. What we are doing in classical RSA is that we pre-oxygenate the patient and then give induction plus paralysis together. What is modified RSA is that after you give the induction, you give the apneic breaths or else you give the or you oxygenate the patient for some time and then you give the paralytic. No bag mask ventilation between the drugs and the induction. What is Selix maneuver is that you give the cricoid pressure of 10 to 20 mmHg. This will actually go and obstructs the esophagus. So the risk of aspiration or as gastric contents regurgitation becomes stopped. Modified RSA is used in the trauma and the critical ill patients. This is most preferred in nowadays because you give pre-oxygenation and then after giving induction, you give the mandatory apneic nasal oxygen throughout the procedure, and you give the gentle bag mask ventilation if the patient is desaturating, particularly in high risk individuals like children, obese, and the shock patients. Cricoid pressure is optional. It is dropped if the laryngoscopic QA is worsening. The 7 Ps of the rapid sequence intubation. A useful way to remember rapid sequence intubation is through the 7 Ps. Let's walk through each one. First one is the preparation. This is the most important step. Remember with mnemonic, that is soak me. Check your suction, check your oxygenation, check your airway equipment. Airway equipment includes your ET tubes, your bougie, stillet, laryngoscopy. P is for pharmacology. Here you prepare all the drugs. M is that monitors. Connect the patient onto the monitor. Preferable is IBP. If it is not available, at least an IBP should be connected to the monitor. Next is E for the equipment. In equipment, you check for all the necessary equipment. Like if you are anticipating the difficult airway, check for the cricoid set. Assign team roles. Ask yourself one question. If my first attempt fails, what is my next plan? Never begin RSI without knowing your plan B and plan C. The second P is the pre-oxygenation. We have already discussed this in detail in the previous chapter. The third P is the pre-treatment. Historically, drugs like fentanyl or lidocaine were routinely given. Current evidence suggests the pre-treatment should be selective, not routinely used. Only use it when there is a clear physiological indication. The fourth P is the paralysis with induction. Push the induction agent immediately followed by the neuromuscular blocking agent. Don't delay between the drugs. Drugs were discussed in the upcoming slides. The fifth one is the positioning and the protection. Optimize patient's position before the attempt. Ramped position for the obesity. Manual inline stabilization if you're suspecting any C-spine fractures in trauma patients. The sixth P is the placement with proof. Getting the tube through the vocal cords is only half of the job done. You must prove it's there in the trachea. We will discuss about the confirmations shortly. Finally comes the post-intubation management. Many learners stop thinking once the tube is in, secure the tube, start the patient on the sedation or the paralysis, adjust the ventilator settings, treat hypertension immediately. Intubation is the beginning of the critical care, not the end. Have a habit of getting a chest x-ray every time you do the intubation. This is the RSA timeline. Rapid sequence intubation starts with giving the induction and the paralysis. It is at the 0 minute. Before 10 minutes, you should start for the preparation, and equipment and consent need to be ready before 10 minutes of giving the induction and paralysis, and before 5 minutes you should start for the pre-oxygenation, and before 2 minutes pre-treatment has to be gone, and 30 seconds post induction and paralysis you should start positioning the patient. Post 45 seconds tube placement has to be done, and post 60 seconds post intubation management has to be begin. This is the rapid sequence intubation timeline. Choosing the right induction agent. One of the common questions that the residents commonly ask to us is that which induction agent is the best? The answer is simple. There is no universal best drug. There is only the best drug for that particular patient. Let's begin with etomidate. Etomidate has minimal effects on the BP and the heart rate. That is the reason why it is an excellent choice in case of the cardiovascular patients and the unstable patients. Its onset of action is rapid, and it provides an excellent intubation conditions. Some clinicians worry about the transient adrenal suppression. Next is the ketamine. Ketamine has become one of the workhorses of the emergency medicine. Unlike many agents, ketamine usually preserves the blood pressure by stimulating the sympathetic nervous system. It is especially useful in the septic shock, trauma, and severe asthma patient because it stimulates the sympathetic nervous system and it causes the bronchodilation. However, remember that profound catecholamine depleted patients may still develop hypertension after giving the ketamine. Now let's discuss about the propofol. Propofol is an outstanding induction agent in stable patients. It provides rapid unconsciousness and reduces the cerebral metabolic demand. However, it causes the vasodilatation and the myocardial depression. Administering propofol to a shock or trauma patients without preparation can rapidly worsen the hypertension. Finally, midazolam. It is useful for the sedation. It has slower onset and a less predictable effects. It is generally not considered a first-line induction agent for emergency rapid sequence intubation when better alternatives are available. The key message is choose drugs based on the patient's physiology, not by the habit. Neuromuscular blockers. Once unconsciousness has been induced, Paralysis creates an optimal intubation conditions. The two drugs which you use are the succinyl choline and the rocuronium. Succinyl choline has traditionally been the gold standard. It acts very quickly and weans off within several minutes. But it's not appropriate for everyone. Avoid it in patients of the hyperkalemia, major burns or crush injuries that is more than 24 hours old, and patients who are with neuromuscular disease and malignant hyperthermia conditions. In these patients, giving succinyl choline can cause catastrophic hyperkalemia. Rocuronium has become increasingly popular these days. At a RSA dose of 1.2 mg per kg, its onset is almost identical to the succinyl choline. One major disadvantage is that it has a prolonged paralysis. However, it can be easily reversed with sugammadex. After successful intubation, you will often use longer acting neuromuscular blockers such as the vecuronium or as the cisatracurium for the ongoing paralysis. Vecuronium is the longer acting neuromuscular blocking agent. It has minimal cardiovascular effects. Its clearance is through the renal or the hepatic. That is the reason why its action is prolonged in case of the organ failure. Whereas when it comes to the atracurium, it eliminates through the Hoffman's elimination. This is organ independent. That is the reason why it is used in the renal or the hepatic failure patient. But one risk is that it can release the histamine. So this is the reason why there is another drug that has come into the market, that is the cisatracurium. This is an isomer of the tracurium. It is more hemodynamically stable and it causes the minimal histamine release. Remember that these drugs are the maintenance agents. These are not designed for the rapid sequence intubation. One final point: never administer a paralytic agent unless you are prepared to ventilate the patient. Paralysis without oxygenation is one of the most dangerous mistakes in the airway management. Now comes the movement everyone associates with the intubation, that is the laryngoscopy. Position the patient properly before inserting the plate. Good positioning solves many difficult airways. As you insert the Macintosh plate, sweep the tongue towards the left side and advance until the vallecula is identified. Lift upward and the forward. Never do rock backward against the upper teeth. Dental trauma is one of the commonest complications of the poor technique. Your goal is not to force for the grade 1 view. Sometimes a grade 2 view is perfectly acceptable if visualization is identified. Use external laryngeal manipulation if only the epiglottis is visible. Introduce a bougie early rather than repeatedly attempting for the directly tube placement. Remember this principle: first pass success matters. Every additional attempt increases the risk of hypoxia, aspiration, airway trauma, and the mortality. Experienced airway clinicians do not persist with the same failed technique. They change something, either the different plate, different operator, or use of the video laryngoscopy, use of bougie, or even the supraglottic airway device. Next is the video versus direct laryngoscopy. Direct laryngoscopy, line of sight is in view with the mouth, pharynx, larynx. This needs the alignment of the three airway axis, that is oral, pharyngeal, and the laryngeal axis. There is no dependency of the screen or the batteries. Batteries to some extent is there because you have batteries inside. This is always available. This is cheap and the portable as well. It has got a steep learning curve. This is harder in the limited mouth opening conditions, or there is reduced neck mobility. It is still an essential core skill even where the video laryngoscopy is available. The one which is being shown over here, this is different kinds of laryngoscopy, that is McCoy laryngoscopy. The advantage of this is that if you could see over here, there is a lever over here. If you press the handle over here, this will further lift the epiglottis. Next is the video laryngoscopy. This has camera near the blade tube. There is no requirement of the alignment of the three axis. This has got high first pass success rate in predicted or is known difficult airways, and in cases who are with C-SPAN precautions. This is preferred in trauma because it doesn't need neck flexion, and this is preferred in limited mouth opening and the obesity patient. So while passing through the mouth, this can be showed on the display. So this allows for the teaching and the team situational awareness during the attempt as well. Next is confirming tube placement. Now you have passed the tube, but your work isn't finished. Now you must answer for the one question: is the tube actually in trachea? There is one gold standard, that is the continuous waveform capnography. If you see a sustained square wave carbon dioxide waveform for at least for 6 minutes, you can be confident about the tube in the trachea. If no waveform is present, then assume that that is the esophageal intubation until it is proven otherwise. Never convince yourself otherwise. Capnography saves lives because it detects misplaced tubes immediately. Of course, capnography isn't the only confirmation method. Watch the tube pass through the vocal cords. Look for the bilateral chest rise. Listen over the both sides of the axilla. If breath zones are absent on the left side, consider it as a mainstem or as the right mainstem intubation and withdraw the tube slightly. Finally, obtain a chest X-ray. But remember that chest X-ray confirms the tube depth. It doesn't confirm the tracheal placement. That responsibility belongs to the waveform capnography. Whenever someone asks, how do you know the tube in the trachea? Your first answer always should be the continuous waveform capnography. Let's summarize this section. Rapid sequence intubation is a carefully planned procedure, not a race. Follow the 7 Ps every single time. Choose induction agents accordingly to the patient's physiology. Understand the strengths and limitations of each of the neuromuscular blocking agents. Focus on the first pass success during the laryngoscopy and never forget that successful intubation is only confirmed by the continuous waveform capnography. In the final section of this lecture, we'll discuss the universal airway algorithm, crash airway, difficult airway, and failed airway management, and emergency cricothyrotomy. Part 4 of our discussion is the airway algorithms and the failed airway. We have now reached what I consider the most important part of this lecture. Everything we have discussed so far, from airway assessment to the rapid sequence intubation, was designed to maximize the chance of success on the first attempt. But no matter how experienced you are, there will be situations where the airway doesn't go as planned. When an airway becomes difficult, panic kills, but algorithm saves lives. The clinician who succeeds isn't necessarily the one who intubates the fastest, it is the one who always knows what to do next. Let's discuss those algorithms. The universal emergency airway algorithm. Whenever you are asked to secure an airway, ask yourself one question before touching the laryngoscope. Which airway am I dealing with? Every emergency airway falls into one of these three categories. One is the crash airway, a predict difficult airway, or a standard airway suitable for routine rapid sequence intubation. This simple decision determines everything that follows. If the patient is unconscious, apneic, or in cardiac arrest, this is a crashed airway. There is no luxury of the prolonged preparation. If the airway appears anatomically difficult but the patient is still oxygenating, then you may prepare equipment, call for help, and formulate a backup plans. If neither of this situation exists, proceed with a standard rapid sequence intubation using the 7 Ps. Notice that the algorithm doesn't end with the intubation. If intubation fails, you must immediately transition to the failed airway pathway. The key lesson is simple: never perform airway management without knowing exactly where you are in the algorithm. The crashed airway algorithm. What is the definition of crashed airway? Is that it is done when a patient is unresponsive, apneic, or the agonal breaths. Patients who are actively dying where there is no time for the standard preparation. So let's say you have a patient who is unconscious or apneic or agonal breaths. Here, there is no time for the sedation of the induction agents. So there is no need of giving it them. If you are having a difficulty in opening the mouth, you can give succinylcholine 2 mg per kg. That is higher dose than of the routine rapid sequence intubation, and then attempt laryngoscopy and intubate them immediately. If it is successful, go for the continuous waveform capnography and the post-intubation care. If it is unsuccessful, then go for the failed airway algorithm, which we are going to see in the upcoming slides. Remember, if you cannot intubate the patient, at least do the mask ventilation. Keep oxygenating the patient while you prepare for the next attempt or call for the help. Next is the difficult airway algorithm. What is the definition is that difficult airway is predicted before an induction, that is lemon positive, or as the known risk factors, that is the patient with the large neck hematoma, morbidly obesity patient. This patient is not yet crashing. You have time to plan. Now let's see the algorithm. If the difficult airway is predicted, ask yourself one question: is the intubation and mask ventilation both are difficult? If both are difficult, then go for the awake intubation technique, either awake with the video laryngoscopy or fiber optic intubation, or prepare for the primary surgical airway. Or else, on the other hand, if only intubation is difficult, go into the back mask ventilation and consider keeping a supraglottic airway device. If both of them are not there, then you can go for the rapid sequence intubation, but with a double setup. What is double setup is that you prepare for both intubation and the surgical trick. That is RSA with the double setup. So what are the things that are needed is the video laryngoscopy, boogie ready, supraglottic airway device ready, and surgical airway kit is opened before the experienced operator is present and the intubation is being attempted. If the intubation is successful, well and good, confirm the placement and go for the post-intubation management. If it is not, go for the failed airway algorithm. The failed airway algorithm, when you call it as failed airway, is that if more than or equal to 3 failed attempts are given by a experienced operator or any failed attempt with can't oxygenate physiology. Let's say you have a failed intubation attempts. One question which you need to ask is that can you oxygenate the patient? If you can oxygenate the patient via a face mask or a supraglottic airway device, now you have time to convert this supraglottic airway device or else the face mask into the definitive airway. Now here you need to call for the extra help and consider an alternative blade or else a device. Consider an awaking the patient if it is possible. If it is not, you need to go for the awake intubation or else walking the patient if it. On the other hand, if you cannot intubate and cannot oxygenate, then you will end up in a condition that is called as cannot intubate, cannot oxygenate condition. Here, only one option which you have is the immediate surgical cricothyrotomy. Please do not delay doing this surgical cricothyrotomy. Many clinicians are intimidated by surgical airway, but in reality, the procedure is straightforward if you have practiced it beforehand. First, identify the cricothyroid membrane using the landmarks. Palpate for the hyoid bone. Move downwards to the thyroid cartilage. Just below it lies the cricothyroid membrane. Stabilize the larynx with your non-dominant hand. Make a vertical skin incision. Then make the horizontal incision through the membrane. Insert a bougie into it and railroad a ET tube along with it. The preferred size is the 6 mm. Inflate the cuff and ventilate the patient. And finally, confirm the tube placement with the waveform capnography. Remember, in a true can't intubate, can't oxygenate situation, every second without oxygenation increases the risk of irreversible brain injury. Next is the special population. Not every airway behaves like a standard adult airway. Children present with a unique challenges. Their occiput is large, their airway is more anterior, and they consume oxygen much faster rate. That means they desaturate rapidly during apnea, like I have shown in the previous graph. Proper positioning and excellent pre-oxygenation are even more important in these patients. When it comes to the trauma patients, always assume a cervical spine injury until it is proven otherwise in case of trauma patients. Use manual inline stabilization instead of a head extension. Video laryngoscopy is often preferred because it minimizes the neck movement while improving the visualization. Severe facial trauma also introduces another challenge. Blood and vomiters can rapidly obscure the camera lens. Never forget the importance of the suction in these patients. A clear view always saves lives. Complications and pitfalls of the airway management. Every successful intubation can have a complication. The most common complication is the hypoxia. Usually, this isn't caused by the difficult anatomy. It is caused by the prolonged attempts. This is why first pass success matters. Esophageal intubation. This is arguably one of the most important catastrophic airway complication. Fortunately, continuous waveform capnography makes it almost entirely preventable. Next is the right mainstem intubation. If breath sounds disappears on the left side, withdraw the tube 1 or 2 centimeters and reassess. Post-intubation hypotension deserves a special attention because you are giving the positive pressure ventilation that reduces the venous return, and many induction agents also lowers the blood pressure. Always anticipate hypotension. Prepare fluids and the vasopressors before induction, not afterward. And finally, aspiration. Keep suction immediately available during every airway attempt. Key takeaways. Let's finish with the principles that I want every emergency clinician to remember. First is recognize airway compromise early. Don't wait until the airway is completely obstructed. Predict difficulty before you administer the paralysis and use the lemon mnemonic every single time. Next is master the basics. Excellent positioning, use of airway adjuncts, bag mask ventilation, and pre-oxygenate prevents many difficult airways from becoming disasters. Fourth is the rapid sequence intubation. When performing rapid sequence intubation, follow the 7Ps systematically. Preparation always comes before the pharmacology. Fifth, never accept an ET tube as correctly placed until you see the waveform capnography. And finally, know your algorithm. Know when you are dealing with a crashed airway. Know when you are dealing with a difficult airway. Know when you are dealing with a failed airway. And if you encounter a true can't intubate, can't oxygenate situation, don't hesitate. Go and perform a surgical cricothyrotomy. Thank you for joining me for this comprehensive discussion on the emergency airway management. If this lecture helped you simplify the airway management or improved your confidence in approaching a critically ill patient, please consider liking the video, subscribing to the channel, and sharing it. So, until next time, stay prepared, stay systematic, and remember, in emergency medicine, we don't wait to lose the airway, we secure it before it is lost. Thank you for watching.